Good day, newly hired nurses. I am Jelly P. Lalic, RN USRN, your training officer. I am here for a teaching demonstration on Basics of Hemodialysis. I will be doing some lecture as a teaching method for this session. May you be able to listen carefully as this will be what will you encounter during your duty in the hemodialysis unit. Let us start with the learning objectives. I am using Bloom's taxonomy for making these objectives so that we could meet these objectives by the end of this lecture session. First, to define the kidney dialysis and its primary purpose, to recognize the basic equipment, machines, and things to ponder during a hemodialysis session. Second, to distinguish different hemodialysis access of patients. Third, to demonstrate the basic setup, especially on the dialysis machine. Fourth, to analyze patient data during dialysis to identify early signs of complications. Fifth, to evaluate efficacy of dialysis session to patients. And lastly, to develop the basics of dialysis for new nurses. First, let's talk about kidneys, dialysis, and the basics. Even though we learn about the kidneys during our student days, yet we need to revisit our lessons, as I know some might forget about it. Since you will be having a duty in dialysis unit, you need to have the knowledge and skills to enter into the battle, which is your daily duty. What is the kidney? A kidney is a vital organ in the urinary system. Humans have two kidneys located on either side of the spine. It is being shaped about the size of a fist. It has major functions, which is first, filtration of blood. It removes waste products, toxins, and excess substances. The kidneys filter waste products and excess substances from the bloodstream. Fluid electrolyte balance. Usually, they regulate the body's fluid levels and maintain the balance of electrolytes like sodium and potassium. It regulates water, sodium, potassium, and other electrolytes. Acid-base balance. The kidneys help maintain the pH balance of the body by excreting hydrogen ions and reabsorbing bicarbonate. It maintains a healthy pH level in the body. Next is red blood cell production. They produce erythropoietin, a hormone that stimulates production of red blood cells in the bone marrow. Next is they regulate blood pressure. Through the renin-angiotensin-aldosterone system, the kidneys play a role in controlling blood pressure. And lastly, they have they do the vitamin D activation. The kidneys convert vitamin D into its active form, which is essential for a calcium absorption and bone health. It converts vitamin D to its active form, aiding calcium absorption. What is dialysis? Dialysis is a medical treatment that artificially removes waste, excess fluids, and toxins from the blood when the kidneys are no longer able to function properly. It is used in chronic kidney failure or acute kidney injury. It acts as a substitute for lost kidney function. There are two main types, hemodialysis and peritoneal dialysis, which we will talk further in the next slides. Hemodialysis. Hemodialysis is a procedure where blood is filtered outside the body using a dialysis machine and a special filter called a dialyzer. There are two tubes in the blood lines. One tube is the arterial, in which blood enters, then flows, then filtered in a dialyzer. The dialyzer will be your artificial kidney that filters blood to remove waste, toxins, and excess fluid when the kidneys fail. It uses a semi-permeable membrane to selectively filter waste products like urea, creatinine, uric acid, the excess fluid like it removes water to prevent fluid overload. It filters electrolyte to balance ions like potassium, sodium, and phosphate, and filters toxins like drugs or chemicals in the blood. After it is cleaned, it is returned to the body and the venous tube. This process will continue for 4 hours, and the dialysis typically is done 2 to 3 times per week in a dialysis center or hospital, depending on your nephrologist. Peritoneal dialysis. In our facility, we didn't do the peritoneal dialysis treatment, yet for you to differentiate, I will discuss about it. A process that uses lining of the abdomen or peritoneum as a natural filter to remove waste and fluid from the blood. Instead of a machine, dialysis fluid is introduced into the abdomen via a catheter. It is in here. So instead of the hemodialysis that is done here through an AVF LVG or in the catheter, in the peritoneal dialysis, it is in the abdomen or the peritoneum. Dialysis fluid is introduced into the abdomen via catheter. Waste diffuses into the fluid, which is later drained. It can be done at home, manually, or within a machine. Now let's talk about the basic equipment and machines inside a hemodialysis unit. So first, everything you see in this slide can be seen in an emergency cart. We have a disposable gloves, cherry balls, used to stop bleeding after getting the cannula from AVG or AVF, sterile gauze used for cleaning the catheter and any bleeding, cotton balls for cleaning a site, dental bib is used as a towel during catheter cleaning. Next is the instrument set, which is on standby for any emergency use. We have syringes in all sizes, a catheter kit or dressing kit for catheter care. Next is the cannula, which is used for the cannula needles used for AVF or AVG cannulation. We have heparin for as anticoagulant so that there will be no cuts in the bloodlines and dialyzer. There are emergency medicines for any complications, IV fluids if needed. Lastly, plain accessories which is needed in the dialysis machine setup for priming the bloodlines or circuit or used for flushing. Here you can see different equipment. We have the hemodialysis machine, which is the most important equipment in the unit. It should be cleaned, well maintained, and in good condition. Without this, no hemodialysis can be done. In our unit, we have 20B bronchodialysis machine, 18 machines for regular patients, and 2 machines for HEPA-positive patients. Bicarbonate and acid or acetate can be seen down the machine, which is used by the machine during dialysis. We also have the blood lines, in which the blood exits from the body to the machine, and this one is the dialyzer, which is the one I said that will be your artificial kidney that filters the blood. Oxygen tanks, nasal cannula, and O2 masks are here. Cardiac monitor, which is used for emergency scenarios. We have the pulse oximeter for checking pulse rate and auto saturation. Stethoscope for checking the breath sounds. Heart sounds, the axis itself, and used for doing BP monitoring. Thermometer is used for checking the temperature of patient. Wheelchair and the stretcher as mode of transport of patients. Nebulizer in case our patients need if they have having asthma attack, the weighing scale, which is important, needed to monitor the weight of patient before and after the dialysis to determine how many kilograms was lost during the dialysis, sphygmomanometer for checking the blood pressure, and of course the patient chair, which is comfy and can be converted to semi-bed as this is their comfort place for 4 hours. Let's talk about the hemodialysis axis. There are different kinds of vascular access. There is a central venous catheter that can be an IG catheter, subclavian catheter, femoral catheter, or permanent catheter. The IG catheter is placed into the internal jugular vein in the neck. The subclavian catheter is inserted into the subclavian vein beneath the clavicle or collarbone. The femoral catheter is inserted in the femoral vein in the groin, while permanent catheter is inserted into the interjugular or subclavian vein but tunneled under the skin. Arteriovenous fistula. Arteriovenous fistula is a surgically created connection between an artery and a vein. This in here. typically in the arm. It is the preferred vascular access method for patients undergoing long-term hemodialysis. Two cannulas are inserted for arterial and venous connection. Arteriovenous graft is a surgically implanted synthetic tube that connects an artery to a vein, serving as an alternative vascular access for hemodialysis when an arteriovascular venous is not visible, meaning if the artery and vein of the patient cannot be used for fistula. It is too small or weak, thus AVG is needed. Thus a synthetic tube rather than an artery or vein is needed. So in the arteriovenous fistula, you are using a vein here, while in the arteriovenous graft, you need a synthetic tube instead of the artery or the vein. Because most of the time, the patient's hands or the veins are weak and small. So same with the AVF, there are two cannulas inserted during dialysis, yet it will be inserted into the synthetic tube instead. As a nurse, you need to know the basic setup on dialysis. Here's a video of what the machine looks like. The bloodline is primed with plain SS and everything is calibrated. I will make another lecture for this in actual, as a video presentation will be difficult to do in actual setting. So as you can see, this is the Vibron machine. And in here, you can see what happened when it's already ongoing dialysis with the AVF fistula and what happened during dialysis. We already know the basics of the machine, so let's learn what's going on during dialysis and to know more on the early signs of complication. What happens during a dialysis session? Before dialysis, the patient goes inside the center, then the triage nurse will assess the patient, then check vital signs like BP, heart rate, temperature, O2 saturation, then check on the patient's weight to determine how many kilograms is gained. Prepare the needed materials for catheter care or cannulation. During this time, assess the vascular access for patency, redness, or swelling. Inform the physician on duty on any untoward assessment. Do catheter care for CVC access and do cannulation for AVF or AVG access. Check for thrill and bruit before inserting cannula to AVF or AVG access. Then the nurse or dialysis technician then set up the machine, prime dialyzer, and tubing with plain SS. Right after that, calibrate the hemodialysis machine, the blood flow rate, ultrafiltration goal, and dialysis fluid composition. Remember, the most important one, check the dialyzer, if it's the patient's dialyzer. Check the name of the dialyzer, because here in the Philippines, we use the dialyzer 5 times. Yet in other countries, they only use once, as it's a disposable dialyzer. When the patient is ready, the machine is calibrated, and the nurse knows that everything is good for initiation, connect the patient to the machine via the vascular access. It can be catheter or AVF or AVG. Administer the coagulant, that could be heparin in some cases. We use Vesel-Ju to prevent clotting. Depending on patient's other factors, we can also use heparin-free or flushing of plain SS instead. Always monitor the patient every now and then, or every 30 minutes to track blood pressure or vital signs, machine parameters, and patient comfort. You can ask them how they are or if there's any discomforts or complications that may occur so that we can do the intervention. There should be therapeutic communication between nurse and patient. Watch for alarms. It can be high or low pressures or just the bicarbonate and acetate almost run out. What machine do? The arterial tubings, the blood enters the flows of the dialyzer, gets filtered, and returns to the body with venous tube. This cycle lasts for 2 to 5 hours for 3 times per week. New patients started with 2 hours and gradually increase every dialysis. When the body is accustomed to dialysis, the patient then set to the regular dialysis for 4 hours. If extended to 5 hours, It means that the patient needs to have a bigger UF goal, or the patient cannot manage to only have 4 hours with a bigger UF goal. That reaches from 4 liters to 5.5 liters. After dialysis will be the termination or disconnection. Flash access with saline, clamp lines, and disconnect. In catheter, we put a heparin lock, a combination of heparin, gentamicin, and plain MSS, so that during the non-dialysis time, the catheter will not be clotted, which will be a big problem for the next dialysis. For AVF or AVG, needles removed and bleeding controlled. Apply sterile dressing to access site, always to prevent infection. For post-assessment, recheck vital signs and weight for us to have basis for next dialysis. Evaluate for immediate complications, example, dizziness, bleeding. Let them relax for a while first before walking out of the center hospital. Patient may feel tired, lightheaded, or nauseous, so check on them all the time, even they are done. The early signs of complication during dialysis, there are a few that you need to be able to be familiar with. The number one on the list is hypotension, which is the most common. The signs are dizziness, nausea, sweating, pallor, or sudden drop in blood pressure. The causes are rapid fluid removal, low sodium in dialysis, or cardiac issues. As a nurse, you then reduce ultrafiltration rate, place patient in tender landward position, and administer saline bolus per protocol. If still with decreased BP, we can administer D50 water as is advised by the physician. Check the vitals every 5 minutes if the patient is already in normal range of blood pressure. Still check every 15 to 30 minutes. Don't worry, we have a physician on duty every dialysis session in the center, and our nephrologists are called away if they didn't visit for the day for any doctor's order for the patient. When you see a patient holding their legs or arms and may look like it's painful, ask them right away. It might be muscle cramps. It can be in the legs, arms, or even abdominal, which is the worst. It is a painful leg or abdominal cramps. It is caused by electrolyte shifts or rapid fluid removal. Usually, if the dialyzer is new, there's rapid fluid removal, thus muscle cramps occur. As a nurse, you then adjust and put the machine to minimum. Give cleanliness, bolus, or D50 water as advised by the physician. Massage cramped muscles if safe, and adjust dialysis sodium concentration or lower the UF goal. Next is clotting in circuit or access. There are signs that visible clots in tubings, elevated venous pressure alarms, loss of urine aid fistula. The cause is sometimes because the patient is on free heparin, or it depends on the clotting factor of the patient. If we have seen a visible clots like this, flash with saline and return the blood of the patient ASAP, as soon as possible. Then notify the nephrologist if none resolved. It is rare and critical, and that is air embolism. The signs are sudden shortness of breath, chest pain, confusion. The cause is that the air entering the bloodstream via dialysis circuit. As soon as you see patient the signs, clamp the tubing, place patient on left side, turn the Lindbergh position, do cupping, administer 100% oxygen as prescribed, and call emergency response if still continues. Next is infection, which can be seen into catheters or CVCs. The signs are redness, warmth, pus at catheter fistula site. There will be fever, chills, or rigors, shivering. Assess the area of infection. Take a picture for documentation and inform the physician. If continues, obtain blood cultures as ordered by the nephrologist. Start antibiotics as ordered, then continue to use sterile gauze and mucosan ointment every catheter dressing care. Next is what we call disequilibrium syndrome. The signs are headache, nausea, confusion, seizures due to rapid solute shifts. The at-risk patients are those who are new to dialysis or have a high BUN levels. The nurse will intervene by slow blood flow rate and, as advised by doctor, a shortened initial dialysis sessions. In rare cases, there's allergic reaction. The signs are a rash, itching, bronchospasm, as it is due to reaction to dialyzer membrane or heparin. You can stop the dialysis, administer antihistamines or steroids, and return the blood to the patient. If continues with all the emergency meetings given, a referral to a nurse hospital can help if you are on a dialysis center. The key nursing priorities to prevent complication is to have a strict aseptic technique, careful fluid removal, and monitoring. There should be patient education. Teach patients to report symptoms like dizziness or chest pain immediately. Whatever they feel, call a nurse as soon as possible. Always have a documentation. Record pre or post weights, fluid removed, vital signs, and intervention. Whatever you do with the patient, document it. What is not recorded meant not done. Always remember that, nurses. Efficacy of dialysis session. How will you know that dialysis session's efficient? First, you have biomechanical markers. KTV dialysis dose, it measures urea clearance. The goal of the KTV is greater than 1.2 per session. URR, urea reduction ratio. The percent of reduction in blood urea pre and post dialysis should be greater than 65%. There is serum lab monitoring every month that we check our patients for their electrolytes, especially potassium and sodium, blood urea, nitrogen, and creatinine, hemoglobin levels, anemic control, and albumin for nutritional status. Second is clinical observations, weight management by knowing the pre and post dialysis weight and compare it to dry weight. Blood pressure, there are stable readings before, during, and after dialysis. Edema, the resolution of swelling in extremities after dialysis is that there's a significant reduce of edema in face, legs, or even in abdomen. There's symptom improvement. The patient felt less fatigue, better breathing, and appetite improvement. You will also know if the dialysis is sufficient by asking the patient feedback. Ask the patient, do you feel less tired after treatment? Are you sleeping and eating better? Any cramping, headaches, or lightheadedness? If the patient will not answer, a family member, companion, or significant other can be asked if they perhaps observe it in the house. We nurses can also do symptom assessment. If there's a fatigue, there's a reduced fatigue during post-dialysis, and it means it's effective. And if there's a persistent exhaustion, it means an ineffective dialysis. If the appetite is improved, it is effective. And if there's ongoing nausea or loss of appetite, it's ineffective. If there's still itching or it's less frequent, it's effective. And if unrelieved pruritus, it's ineffective. If the shortness of breath is still noted and unresolved, then it's an effective dialysis. If it's still persistent, it's unresolved. Most of the time, patients have shortness of breath if there's increasing fluid in the body or have a missed dialysis session. Next is muscle cramps. Absent or minimal, it means it's effective. Then if it's inefficient and ineffective, they're still frequent during or after dialysis. We can also check for long-term outcomes. Track over weeks or months to assess overall dialysis efficacy. Hospitalizations are lesser or fewer. Admissions for fluid overload, hyperkalemia or uremia. The lab trends are being stable in hemoglobin due to managing it from erythropoietin injections after dialysis. Survival rates, reduced mortality or death linked to adequate dialysis. Now, you nurses develop the basics of dialysis. Just remember, act immediately to prevent any escalation of complications. Inspired by Gene Watson's philosophy, dialysis is not just about filtering blood, it's about restoring hope one treatment at a time. Thank you. Any questions or clarification, just ask me. I am ready to help. Any new knowledge you want to learn, I am here ready to assist and teach you. Wish you will love being a dialysis nurse and be with us long term. Once again, I am Charity Lalic, your training officer. Have a great and meaningful duty ahead.